Today, we're clearing up one of the most confusing issues in women's health: progesterone versus progestins. They sound the same, but they act very differently in your body, and healthcare often gets it wrong. Joining me are two of the world's top experts, Dr. Jerilynn Prior and Dr. Jim Simon. You'll hear where they agree, where they debate, and what you need to know to advocate for yourself. So let's dive in. Dr. Simon and Dr. Prior, it's so great to have you both here. I'm going to just get right in, and we are going to talk about first the foundations, which is what is the difference between progesterone and synthetic progestin, and what does it mean in terms of risks and benefits? So who would like to start? Dr. Prior, maybe you can begin. And by the way, can I just say how this whole podcast started? Dr. Simon and I had a debrief because he had presented at the FDA hearing on menopause, and he and I were chatting, and I told him about my frustration about the progesterone progestin mix-up that I keep hearing. And Dr. Prior, you have even said that you've seen papers where the terms are interchanged. So he and I were speaking, and I said, I need to do an episode on this. And he said, we should bring Jerilynn Prior in and let's just have the discussion. So here we are. So let's talk about that difference. Can we start there, please? Dr. Prior, I'll have you go first.
Progesterone is a hormone that women's body, well, men's and women's bodies make. And therefore, we have a better understanding of how it works in every tissue in women's bodies. Whereas progestins, although they meet two criteria, one is they change the lining of the uterus so it's secretory or looks like the action of progesterone, and they have to preserve a pregnancy. But otherwise, we don't know anything about how they work in breast or brain or bones or any of the other tissues in our bodies.
Dr. Simon, do you have anything to add to that?
I would add, first, I clearly agree with Dr. Prior, but I would add that our language tends to confuse this phenomenon. We talk about progesterone and progesterones, which is a word that doesn't exist. And I think that there are parts of the business community that would prefer that this confusion persist, because progesterone, as Dr. Prior noted, is a natural, body-identical compound that we've had in humans and most mammals, by the way, for many, many, many millennia. And natural is good, and normal is good, and knowing about stuff is good. And if we can confuse it with what we don't know about, then by its very nature, those other compounds get some of the benefit of what we know about progesterone in being natural and normal and good, whether it's true or not.
Right. And go ahead. Were you going to say something, Dr.
Yeah,
Prior?
I was going to say that I think one of the roots of the problem is that gynecology has accepted a term called progestogen. And this is apparently a bin in which progesterone and progestins both fit. But I think that is wrong. Progesterone is in its own bin. Everything else is synthetic and a progestin. I think we should take that progestogen out of the literature totally.
I think the other thing, Georgie, that goes more to your interest in contraception is the fact that progesterone, the naturally occurring compound, is a really bad contraceptive agent. And as a result, mix-up of the synthetic forms that are commonly used in contraception that are better at contraceptive efficacy with what's natural, which is the progesterone. And when we lump it all together, it seems better when scientifically it's confusing and not better, as Dr. Prior noted.
Okay, that's fair. So you mentioned body identical. I just want to also clarify this term because I follow a lot of conversations also on social media. And There are some who are like, I am sick of this bioidentical, body identical. These are marketing terms. So can we please, because you are clinicians, researchers, well respected, can we please put this to bed? Who would like to start?
I can
It's
jump
pretty
in.
simple. It's
I
it's
can,
not marketing, it's reality.
yeah, I can jump in and give a little perspective. So, in the aftermath of the Women's Health Initiative, which the hormone studies were published in 2002 and 2004 and multiples since then, there was a desire in the compounding business to separate what they were compounding from what were used in those studies. And the term bioidentical was born of a marketing notion. It was a good term. Bioidentical or body identical meant that the compound was by its structure natural to, in this case, human bodies. And I didn't dislike it in spite of where it came from. Body identical is the next iteration of that. And in a clinical sense, I don't have a problem with patients knowing what is identical in their bodies because it's reality. At least they know it's identical. Now, there are a lot of nuances that Dr. Prior and I can go into as to whether a pill, a patch, a pellet, a paste, a vaginal ring, etc., actually delivers what is a bioidentical compound into the body when it stays in a bioidentical way or not. But that's a bit in the weeds. And so we can talk about that separately. But body identical, bioidentical do have an important, albeit simplified, clinical understanding, which I think is a good thing for women.
And it's important to know, and I would like to remove us from the horrifying connotations for most people in the United States of compounding. And in Canada, any hormone has to be prescribed. The problem in the United States is that compounding can get around that kind of thing. And so anyone can order some kind of compound and it's fine. Okay, so, but here's the important thing. And that is that we now have FDA and Health Canada approved bioidentical hormone therapy, both for progesterone and for estrogens. And for estrogens, they come as both a patch or gel, which is ideal, and also as a pill. So in other words, this is not something airy-fairy. It's something that any clinician can prescribe.
As for formulations, just since you brought that up, do you mind just helping us understand some of the effective ones? And I ask this because, you could get an OTC progesterone cream that's made of the yams or whatever. So, and I know some people are trying to use that. And so maybe if you could just tell us from the progesterone perspective, the importance of formulations and not deep dive, but just a general summary of what's the best.
So let me start, but I'm going to let Jerilynn carry the ball largely. So progesterone, by its very nature, is a compound that needs to get into the body in pretty significant amounts compared, let's say, to estrogen. And because of its structure, doesn't like to get through the system, doesn't like to go through your gastrointestinal system, doesn't like to go through your skin, doesn't like to go through your nose or whatever. By its structure, we need to get a lot in, and it doesn't want to go in. That's really part of the issue. And it's something that I hope to have set Dr. Prior up for to talk directly to your question. But the answer is the structure of the actual compound does not lend itself to being absorbed in large amounts.
Fair enough. And one of the important things that we need to cover is that when you want to give a full luteal phase equivalent dose of oral micronized progesterone, the natural form that we have as a compounded capsule, you have to give 300 milligrams, and you need to give it at bedtime. The reason for bedtime is because its major side effect, if you will, is drowsiness. So it improves deep sleep. And unfortunately, the dose, the original size of the capsule is 100 milligrams, and you need 3 of them, which seems like, quote, a lot. In the body, estrogen is in different lower units, 1,000-fold smaller units than progesterone. In other words, the body makes more progesterone than it makes estrogen just because of the needs of the body. 300 milligrams is needed if you're going to have a progesterone effect on most things. That's been shown to improve sleep, to improve night sweats and hot flushes in menopause, and to improve night sweats and sleep in perimenopause.
Okay. And well, since you dove into the menopause piece, because I want to get into, maybe we could just do this quick thing because I think we need to talk about why we don't talk enough about progesterone. So let me set this stage. Is Dr. Prior? Yeah, go ahead.
1 second. So I'm not disagreeing with Dr. Prior. She is correct, but she's giving you the average amount.
Okay.
There are women that will require or tolerate less, and there are women that will require or need more. On average, I would agree, 300 milligrams at bedtime, but that's an average. And women come in big packages, small packages, fat packages, thin packages.
Yep.
Some of them metabolize medications and hormones quickly. Some of them metabolize them slowly. Some are better absorbers, some are lesser absorbers, but the average is 300, and there's variability. Let's celebrate the variability, but let's remember that there is that variability.
I totally agree.
So, okay, well, then let's keep going on this topic. I know when I was prescribed progesterone, because I am on menopause hormone therapy, so I'm on the patch, and I was obviously given progesterone to protect the uterine lining. And I was given 100, and I'm the one who's having to advocate because I know Dr. Prior, and we have had many discussions about progesterone that I can get to 300. And my question now is, if everyone's body is different, how do you even know if you're on the right dose? Because honestly, for me, the thing I'm most concerned about, and I would assume our clinicians are most concerned about for women, is the protection for the uterine lining, right? Bone density and so many other factors. So how does one know outside of how one feels if they have the right dose?
Well, the dose in menopause hormone therapy depends on the dose of estrogen, because you need to block the effects of estrogen on the uterine lining. Estrogen is a very powerful hormone. It makes every tissue grow, and it continues to make tissue grow. That's the reason progesterone is so important, because it counterbalances and slows that potential overgrowth caused by progesterone.
My mind is blown. No, I don't think I've ever heard anyone discussing it in this way, and it makes sense. Dr. Simon, I'd love your reaction.
No, I think that's absolutely correct. I would like to answer your question more directly, and it's going to seem like it's a Washington, D.C. answer because we here in D.C. have a lot of politics, but it's not meant to be.
Okay.
So the regulators, whether they are Health Canada or the FDA, have in their heads, and for some good reasons, not always good reasons, but for good reasons, that we should be using the lowest dose of whatever it is that is able to create or affect whatever we're trying to create or affect for a reasonable or short period of time. That is a treatment mentality rather than a preventive or a normative mentality. But the answer is that's what the labels for all of these agents say, and how drug companies are forced to develop drugs. What's the lowest dose of progesterone that we could give the average woman, let's say on a daily basis, to prevent the uterine lining from growing in menopause in a woman who's on a low dose of estrogen. And so we come up with 100 milligrams
Low
rather
dose of
than
estrogen is not always the case.
absolutely. So we have to evolve in our thinking as practitioners when a woman is on a higher than a very low dose of estrogen, or she wants a truly progesterone related effect outside this little low dose for her uterus, or she doesn't absorb it well, or she metabolizes it a lot, or she has bleeding suggesting that she's not getting enough antagonism for the estrogen dose that she is on, etc. So these are guidelines and the approach to a treatment effect, not a prevention effect, and are not individualized, which is something that we in the clinic must do to provide personalized care to a woman who either has a problem or has a different need or is looking for a different effect than just preventing the estrogen impact on her uterus in her body.
Georgie, if I can,
Please.
the idea of the lowest amount of hormone is applied in real life to progesterone, but it's not applied to estrogen. The concept is more is better for estrogen and less is better for progesterone, and that's not correct. So as a clinician, I would get back to you and say, what are you trying to achieve with estrogen and progesterone therapy in menopause?
I mean, I have to say, I think a lot of women might say, I don't know, because I don't know what I don't know,
But
right?
that's a concern. It's a real concern because I don't think there's any evidence that taking hormones in menopause, if you don't have hot flushes or sleep problems, is going to enhance your life, prevent heart attacks, prevent whatever. I think it's a wrong notion that we're deprived of estrogen when we're menopausal. I've been menopausal for over 20 years and I'm not deprived of estrogen. This is a normal phase of life, and it's normal to have low hormones in this phase of life.
Dr. Simon?
So I take a little different approach. I think that humans, and in fact, nearly all animals on Earth, never had a time of life after reproduction. Because nearly all animals on Earth, except perhaps animals in zoos and our house pets, all of us died when reproduction was over or shortly thereafter.
But
And that still remains the case. And so most animals die when their reproduction is over. Humans don't die when their reproduction is over. And I think the difference between Dr. Prior's thought process that menopause is a natural event and doesn't need treatment is one argument. Mine is that we haven't had millions of years of evolution of women living past their reproduction or past their menopause. And so we haven't, as humans, evolved the mechanisms to make that estrogen, low estrogen state normal, in spite of the fact that menopause clearly is a normal event. And we're never going to agree on that. It's a different point of perspective. One point of perspective is, as Dr. Prior clearly enunciated, that she's fine, she doesn't need anything, and she's okay with low hormones of menopause, the natural state of affairs of menopause. And my argument, my approach would be there are biologic reasons for women to be on hormones past menopause and to maintain some of those hormonal benefits of the premenopause and evolve with hormones to see if and to understand if we can increase the reproductive lifespan, at least in terms of hormones.
okay, so first of all, there's strong historical evidence that women have lived to old ages. I mean, that it's recorded in the New Testament, in the Old Testament, it's recorded in many, many cultures. What is different is that we're surviving childhood now. Infectious diseases in childhood and infancy used to mean that the life expectancy of someone was very low. That's quite true. But the idea that that makes menopause abnormal is just wrong. And if you say menopause is abnormal, then the natural thing is you must take something to replace what is women now no longer have. That's using a male model because men don't lose their testosterone as they age. It only dribbles down very slowly. And that's just not an accurate understanding.
So if I may,
Yes, please.
because I wasn't necessarily planning the debate on hormone therapy. So I think these are very interesting perspectives.
They're not reconcilable, Georgie.
I know.
Yeah. It's you say that women are insufficient, unhealthy for the last 30 or how many years of their lives. And that's just not, I mean, I refuse to accept it. It's paternalistic and it's not accurate physiologically.
May I ask, because we are here to definitely talk about progesterone and its benefits and the differences between progesterone and progestin. And so may I bring us back then to the differences between these two hormones?
Yes, please.
And
I'd like to make the point that I said at the beginning, and that is that we can know from physiologic studies and from observational data the actions of progesterone in different tissues. But we can't know, unless a study is specifically looked at it, the actions of a progestin in different tissues. And the best example is that medroxyprogesterone acetate, which was used in the Women's Health Initiative, has similar actions, acts through the progesterone receptor in bone, but it acts through the glucocorticoid or cortisol receptor in the breast. In other words, we didn't know that. So it increases breast cancer, and that is not what progesterone does. So it acts different than progesterone in the breast. So the same is true for all of the progestins that are made from testosterone sometimes, from mineralocorticoid binding thing, other times from progesterone, other times. And even some progestins are metabolized and excreted through estrogen. And, how is that a progesterone effect?
so may I just clarify, to backtrack, in the WHI study, there was an estrogen and progestin arm and an estrogen and progesterone arm. And
No. There was an estrogen alone arm in women who'd had a hysterectomy or a hysterectomy, ovariectomy, and there was an estrogen and progestin arm. And it was a prevention trial. They weren't treating hot flushes. They tried to avoid enrolling anyone who had really bad sleep or really bad hot flushes, because we were trying in that trial to find out whether hormone therapy was preventative of the things that bother us as we become older.
Dr. Simon.
So I would also say that while we are focusing on this discussion on the differences between progestins and progesterone, and clearly the Women's Health Initiative used a non-bioidentical form of a progestogen, in this case medroxyprogesterone acetate. I would also argue that it didn't use a naturally or bioidentically normal type of estrogen. It used conjugated equine estrogens, and whether you like conjugated equine estrogens or you don't like conjugated equine estrogens, it's not a natural bioidentical estrogen, for better or worse. And so the study itself, while it gave us a lot of important information, I'm not sure it gave us a lot of important information on the question of bioidentical, body identical estradiol or progesterone. So, and the problem there with that conclusion is that the regulating agencies, both Health Canada and the FDA, took the results of the WHI study, as did the EMA in Europe, and made changes to the regulation of all hormones, whether body identical, bioidentical, vaginal, etc., based on the results of this very large clinical research trial that didn't involve any of the chemical agents or compounds that Dr. Prior and I have been talking about with you on this podcast.
So then may I move to the next question, because this is one of the things that influenced me wanting to have this conversation in the first place, which is I speak to so many women who are on the estrogen patch, most are on the patch, and they say that they're on the Mirena IUD and that their doctors do not prescribe progesterone. And I'm concerned about this. And I'm very curious from the two of you if this is concerning. So if a woman is needing to take, and by the way, the other confusing part of this is they're taking the IUD because they're in perimenopause. They may not know if they're in menopause. That's a whole other layer to this. But I guess the formula here is if said woman is on the patch with the Mirena IUD or just given birth control, right? Is that not the smart thing to do, and they should be on progesterone? That's really my question.
Okay, let's not confuse perimenopause and menopause
I
here
know.
for a minute. And
That's
I would like us to talk only about menopause at the moment. And I would just say that the Mirena IUD releases or elutes a progestin into the local uterine lining and will prevent endometrial cancer.
okay.
However, it doesn't provide the other, some of them unknown, benefits of progesterone in the rest of the body. That notion of take estrogen as a patch, use the Mirena IUD, arises from the concept that progesterone only works in the uterus. That's a concept that is still taught, but is wrong, because progesterone works wherever estrogen does, and it's necessary wherever estrogen is acting, because they are meant physiologically to complement each other and counterbalance each other.
Dr. Simon?
So I think that it really depends on what the goals are. We already talked about the benefits of natural progesterone outside the uterus, sleep being one that Dr. Prior mentioned. And let's imagine a woman who's using the IUD as prevention of the stimulatory growth effects of estrogen on the uterine lining. I think we can agree that that IUD is going to work for that endpoint. But let's imagine that woman and her identical twin sister, one of them who sleeps great and has no sleep issues, and the other that's having terrible sleep issues, and they are the exact same person, and they're both identical twins. One might benefit clearly, directly, without experimentation, on having progesterone added for the benefit of sleep in her case. The other might choose not to take any progesterone, in spite of the fact that I agree with Dr. Prior, there are extrauterine benefits and effects of natural progesterone. But this twin, the other twin, may choose not to use progesterone for sleep because she perceives that her sleep is perfect from the get-go. So I think the take-home message for your audience is that while there may be scientific benefits from progesterone, there may be women who have side effects from progesterone. We need to look at her, whoever that woman is in my office or Dr. Prior's office, and find out what her goals are, what her levels are, and tailor our scientific understanding to what might be best for her.
Okay.
I love that you two see so differently on some of these things.
We don't know for sure that that woman on estrogen and Mirena IUD, levonorgestrel releasing IUD, is not going to have an increased risk for breast cancer. We don't know that. There is some systemic absorption of the low dose progestin in the IUD. And, it's one of those things that the FDA and many people are blinkered. They can't think physiologically because of that concept that progesterone only works in the uterus. So I'd like to talk about perimenopause for a minute, because I think I know that the hormonal milieu of perimenopause is very different than the hormonal milieu of menopause.
Yes.
And at the present moment, we do not have any therapy other than progesterone that's been shown to be effective for treatment of night sweats and sleep problems, the two main things that bother perimenopausal women. And yet, all over this world, in every regulatory body and every menopause or other type society that gives guidelines, say it's fine, it's recommended to give estrogen and progestin or progesterone in perimenopause. And I find this is very strange, because without a randomized controlled trial, how do we know it's safe? How do we know it's effective? And there has not been a large randomized controlled trial adequately powered of estrogen and progestin or progesterone in perimenopause.
Fair point. And this is one of the issues with so many women's health questions, where we just don't have enough of the studies. One more question, though, about how you describe the Mirena IUD. So what about if someone is on a pill, the birth control pill, that is progestin? Does that act the same way as the Mirena IUD? Because the IUD is placed in the uterus.
The birth control pill is,
Okay.
they have to be
Okay.
protective.
Oh.
And so enough progestin to balance
Okay.
the high dose estrogen.
Okay.
Georgie, it's why women who are taking birth control pills have very light or many times no periods or bleeding episodes, because the progestogen that also affords contraception from those pills provides significant anti-estrogen effect in the uterus, and so there's little or no uterine lining to bleed under those circumstances.
Okay.
But
Yeah,
that's a different comment from what Dr. Pryor's talking about in the perimenopause. We've just discussed, and what I've just emphasized, those are pharmacologic effects, not physiologic effects. And Dr. Pryor's comment, which is a very apt one, is that we don't have good understanding of or treatment data, particularly long-term treatment data, of the perimenopausal woman in her altered hormonal milieu. We know it's altered, that's without question. We know that she has side effects of those alterations, simple ones like heavy menstrual bleeding or increase in her premenstrual symptoms or irregular periods. Those are without a doubt true, but we just don't have an understanding, either a physiologic one or a treatment one, for what would happen if we replaced, if you will, in a physiologic way in that perimenopausal woman, estrogen, natural estrogen and progesterone, and how would those things affect some of these non-uterine focused, maybe non-gynecological even focused changes that women have during that time frame.
So I would like to give my physiologic perspective on what's happening in perimenopause. And through most of perimenopause, until at least a person has skipped a period, which would say they're in late menopause transition or whatever, estrogen is dramatically increased and swinging. Even in asymptomatic women, it's statistically significantly higher than in premenopausal women. Estrogen is higher, stress hormones are higher, and progesterone is lower than in premenopausal women. So that occurs because the body has changed or prevented the normal feedback loop by decreasing inhibin beta or B. So why would giving more estrogen to someone whose estrogen is already high fix a problem? It doesn't make any sense to me. potentially could give toxically high levels of estrogen.
Do you have additional thoughts, Dr. Simon?
No, I don't. I think we need to do some studies in the perimenopause to test that hypothesis to prove that it's true, or that we could offset the high levels of estrogen by giving more natural progesterone. But
Yes.
I don't think those studies have been done or
Right.
are even thought of or planned. I think it's a reasonable hypothesis.
I did a meta-analysis published in Endocrine Reviews as part of a big review of perimenopause endocrinology in 1998. And that meta-analysis showed what I just said, that within center, women who were perimenopausal, as defined by the clinicians in that center, had higher estrogen levels than did premenopausal women, matched for cycle phase. That's not hypothesis. These are data. And we know that the feedback loops are broken because inhibin B is an important one in controlling the amount of FSH and therefore the number of follicles that are stimulated in each cohort.
Clearly, we need more data. If I may just summarize the way I understand it to make sure the takeaway is appropriate here. Progestin and progesterone are different.
Yes.
And progesterone, we understand, has more broader protective effects than the uterine lining, whereas the progestin is more focused on protecting the uterine lining when you're taking estrogen. Dr. Prior, am I missummarizing based on the look on your face?
Progestins are stronger at protecting the uterine lining than progesterone, especially in the low doses that are often given now.
Right. And then the other is making sure that we're dosing progesterone properly. And it sounds like based on if you're in menopause, the amount of estrogen you're taking as hormone therapy and other factors in your body should drive the amount of progesterone you're taking. So just getting that 100 milligram pill may not be sufficient for you. Is that also correct?
Especially if you have sleep problems
Okay.
and you need more.
If you have the IUD, would the recommendation be to still be given progesterone and ask your doctor to
Especially
prescribe
if
that?
you have sleep problems.
Okay.
Because progesterone helps sleep and the IUD doesn't and estrogen doesn't.
Okay. Dr. Simon, anything to edit in that summary or to add?
No, I think the important addition that I would continue to emphasize is that we think about women as being this monolithic and singular organism when in fact they are clearly not, and that we in the medical profession need to listen to women and address their individual needs. And while we can start from one size fits all, we need to adapt and evolve those approaches uh, to the degree that they are practical for an individual, to her and her alone, which may mean more progesterone if she has sleep issues. It may mean less progesterone if her uterus is being protected by an IUD, if she doesn't have sleep issues or she has side effects from progesterone. But the real answer is individualization, personalization of care, not science. We got to figure out the science, and there's big gaps in our understanding of the perimenopause and menopause. But in terms of care of patients, we need to individualize.
I think one thing is missing from our discussion, and I'm not sure that this is the case in the United States, but it's certainly the case here, that progesterone costs a lot more than most progestins. And that's not the case in Europe. An equivalent dose is similarly priced. And unfortunately, most health insurances don't pay for it. And even the body overseeing the payments for drugs in BC is still saying medroxyprogesterone is similar to and can be used instead of oral micronized, which is wrong.
I will say I have to fight for my prescription. And, in the US, we get 30-day or 90-day supplies. And do you know that I'm on 200 milligrams and I only can get every 12 days? It's really frustrating.
I think the concept of the side effects of progesterone are not based on clinical trials. I've done 2 major clinical trials of progesterone, one in menopause and the other in perimenopause. And in neither case did I find any significant or show-stopping adverse effect from 300 milligrams of oral micronized progesterone
Okay.
in a
Well, good.
blinded trial.
Okay. Well, anything else to add? This was quite a discussion, having 2 individuals that have unique perspectives in some of the areas. And so I just want to make sure we've covered anything. If you had any other last thoughts to share.
So I don't think either my perspective or Dr. Prior's perspectives are particularly unique, but they are different, and they represent 2 very different camps or approaches. Even though they're different, neither is well documented or founded, but they look at the issues from 2 different perspectives, not right and wrong, not good and bad, just different. And when there are such differences, it's important that we, the big we, both perspectives, fight to get the research funding to help answer those fundamental differences. And that, I think, Dr. Prior and I and all of your viewers should be able to get on board with. Let's not say Prior's right, Simon's wrong, Simon's right, Prior's wrong. Let's get the research funding to answer the fundamental differences. And then one of us will say, well, you were right. Or the other will say, you were right, but we'll have the answers, and we don't have the answers now. And that's okay. It's okay that we don't agree. It's good that we don't agree, but it's not good that we don't have the research answers to reconcile our disagreement. That is not okay.
When you see patients coming in, what do you wish patients would do to help advocate, and how can they advocate for themselves in this kind of a situation? And then what do doctors do as well? My conclusion is a 2-way dialogue, right? But it's also making sure the doctor knows the research.
I think the basic thing is to come back to each woman. And if a woman keeps a kind of a record like the menstrual cycle or perimenopause or menopause diary, she will know what's concerning her when she goes to see the doctor, and she will know if the treatment is fixing whatever she's concerned about. So that becomes an experiment of one. And so that's the way in which I think we solve the problem until we get better funding for large studies.
Okay, that's fair.
It's a very good approach. Take that individual, tell her, give me the 5 things you're concerned about, or that you've kept in your diary, or that you've kept in your menstrual record, or on your calendar, whatever. And let's check them now and check them after whatever the treatment is that we're deciding to use, and what's better, what's worse, and what's the same. And let's modify the approach to get the best benefit for the buck and also for the patient's bigger picture, and maybe other medical problems that she has, to look at her as an entire being, not just her uterus or her breasts or anything else. And that's the art of medicine.
Yes,
right.
Absolutely. Well, thank you both so much for coming together and having this conversation. And I appreciate the respect that you have for each other, and even in differing views on this. Have a wonderful day, and I look forward to sharing this with the broader audience. Thank you so much.
Thank you.